Hello, everyone, again. Um, Today is our session on compassionate closure, end of life care, and nursing ethics. As future nurses, you will face some of the most challenging and profound moments in healthcare, which is caring for patients at the end of life. This isn't just about medical procedures, it's about dignity, difficult decisions, and moral responsibility. And today, we'll explore what it means to provide compassionate end of life care within the Filipino context, while understanding the ethical frameworks that guide our practice and apply the ethical principles through real world scenarios. Okay? Before we dive in to the contents of our discussion, let's review first our learning objectives for today. By the end of this session, you will be able to first understand end of life care, what it is, why it matters, and its core principles. And this foundation is essential. Second, uh, for you to be able to appreciate both the global context and our Filipino context, how culture and religion shape our approach to death and dying. Third, to understand dignity in death and dying, what this means in nursing practice. Fourth and fifth, analyze ethical conflicts around prolonging life versus euthanasia and differentiate between quality of life and sanctity of life because these are complex but crucial distinctions. Sixth is to apply this ethical decision making process in nursing practice, which is a practical tool that you will use throughout your career. And finally, to evaluate end of life scenarios using the classic moral evaluation, looking at the act, the intention, the circumstances, and outcome for you to analyze the morality of a particular action or decision. Now, which of these objectives do you think you feel most uncertain about? And which of these do you think will be most challenging in practice? Okay, so take a pause and try to think. Now let's start now with our discussion proper. Let's start with the fundamental question: what exactly is end of life care? Okay. It is a comprehensive care provided to individuals who are nearing the end of their life. Notice the word comprehensive. It's not just about managing symptoms or preparing for death. It's about improving the quality of life for both patients and their families. The focus is on relief of suffering, pain management, symptom control, but also emotional and spiritual support. Okay? It's not just about dying, it's about living as fully as possible until the end. And this requires a multidisciplinary team. Nurses, of course, the doctors, social workers, the chaplains, and crucially, the family members. In the Philippines, family involvement is especially significant. Think about it this way: end of life care shifts the goal from curing to caring, from fighting disease to comforting the person. It's a fundamental shift in how we approach patient care. Okay? Now, if end of life care is so important, why is it not more widely available? Let's explore. Um, let's look at the statistics and benefits. Globally, according to statistics, we have an aging population and increasing number of chronically ill patients. The demand for end of life care is growing rapidly. The benefits are clear. It improves the quality of remaining life. It reduces unnecessary hospitalizations and invasive procedures that don't benefit the patient. It provides emotional and spiritual support to patients and families during one of life's most difficult transitions. And perhaps most importantly, end of life care enables patients to die with dignity and in comfort. But here's a concerning reality for us, no, here in the Philippines. Only 10% of our hospitals have palliative care units. Think about that, 90% don't. So this means most Filipinos who need end-of-life care don't have access to it. As nurses, you're often the frontline providers, no, who must bridge this gap. Uh, in simple terms, if there is no one available, no, there is no official unit to care to provide end of life care, then we the nurses, no, are bridging this gap. And this highlights the critical need for nurses trained in end of life care. You may be the only source of comfort and support for patients and families in many settings. End of life care is guided by several key principles. Let's go through each one. First, it is a person-centered care. This means respecting the individual's values, beliefs, and preferences. It's not about what the healthcare team thinks is best. It's about what the patient values. Right? The next is uh, it has a holistic approach. We must address physical, psychological, social, and spiritual needs. Now, a patient in pain needs physical relief, but also emotional support, spiritual comfort, and social connection. In the Philippines, this spiritual dimension is particularly important given our predominantly Catholic population. Next is communication. Open, honest, and compassionate communication with patients and families is important, no, during end of life care. This is one of the hardest but most important skills. In Filipino culture, there's often a tension between protecting hope through non-disclosure and respecting autonomy through truth-telling. And we must be able to navigate this well, no, through open, honest, and compassionate communication with patients and families. The next is symptom management. Aggressive pain and symptom control is about symptom management. No patient should suffer unnecessarily. This includes the principle of double effect, no, that we will discuss later. Next is support for family, including family in care decisions and providing bereavement support. Now, Filipino families are close knit and their involvement is essential. Okay. Next component is cultural sensitivity, respecting cultural and religious traditions around death and dying. In the Philippines, this means understanding Catholic views, no, on suffering, the sanctity of life, and unique Filipino death rituals like the 40-day mourning period. Okay. Now that we understand what end of life care is and it's important, let's look at the global context. End of life care is a global challenge. Let's look at some WHO statistics. Each year, it is said that an estimated 56.8 million people need palliative care. That's more than the entire population of many countries. Most of these people live in low and middle income countries. Shockingly, only 40% of countries report that palliative care services reach at least half of patients in need. That means 60% of countries don't even reach half the people who need this kind of care. And here's perhaps the most troubling statistic. 79% of the world's population consumes only 13% of the morphine used for pain management. So think about that. Most of the world's people are suffering in pain without adequate medication. The disparity between wealthy and poor countries in access to pain relief is a matter of global concern. The major barriers include national health policies that don't include palliative care at all, limited or non-existent training or for health professionals, inadequate access to opioids, lack of awareness among policymakers and the public, cultural and social barriers, and misconceptions about palliative care. Okay, now what conditions require palliative care? The majority are chronic conditions or chronic diseases. Cardiovascular diseases account for 38.5%. Cancer, 34% of cancer patients need end-of-life care or palliative care. No, I mean palliative care. Chronic respiratory diseases, 10.3 of these needs palliative care. Those people with AIDS need 5.7%. And even diabetic patients, 4.6 of diabetic patients need palliative care. But many other conditions also need palliative care. Okay? Understanding when death occurs is fundamental to end of life of care. To end of life care. Now let's examine the definition of death this time. So when does death occur? This seems like a simple question, but it's actually quite complex and has important legal and medical implications. By medical definition, death is the irreversible cessation of biological functions that sustain life. By legal definition, through the Uniform Determination of Death Act, which guides state laws, defines death in two ways. First is either the irreversible cessation of circulatory and respiratory function, wherein the heart stops beating and cannot be restarted, or the irreversible cessation of all functions of the entire brain, including the brainstem, which is called brain death. Okay? Now, these two types of death determination have different implications. For circulatory or cardiac death, this is what most people think of as death. The heart stops beating and cannot be restarted. In many cultures, including the Philippines, this is the traditional understanding of death. Now, for brain death, this is the complete and irreversible loss of brain function, even if machines are keeping the heart beating. Now, this definition was crucial for the development of organ transplantation, as it allowed organs to be retrieved from patients whose hearts were still beating but who were legally dead. Okay? These definitions are critical for end-of-life care decisions, and as we will see later, for organ donation timing. As nurses, you need to understand both definitions because they affect when treatment can be withdrawn, when organs can be donated, and how families are supported through the dying process. The concept of brain death has a fascinating history. Let's explore how Harvard University defined it in 1968. Okay, so in 1968, a Harvard committee made a landmark decision that would transform end-of-life care and enable organ transplantation. They defined irreversible coma, what we now call brain death. The Harvard criteria established 6 requirements for determining brain death. First is unreceptivity and unresponsiveness. The patient shows no response to any external stimuli, including the most painful. Number 2 is no movements or breathing. There are no spontaneous movements or respiration. The patient cannot breathe without mechanical support. Number 3, no reflexes, absence of brainstem reflexes. This includes no pupillary response to light, no corneal reflex, no oculovestibular reflex, no gag reflex, and no response to noxious stimuli. Number 4 is flat electroencephalogram or EEG. A flat EEG repeated after 24 hours with no change is one criteria. This shows no brain electrical activity. Again, a flat EEG repeated after 24 hours with no change. Okay? The number 5 is the apnea test. Disconnection from the ventilator for 3 minutes shows no breathing. This tests whether the brain can initiate breathing on its own. Okay, so that is the apnea test. And number 6 is the exclusion of hypothermia or central nervous system depressants. The patient cannot be suffering from hypothermia or be under the influence of drugs, that could depress the central nervous system. Now, this definition was revolutionary. Before 1968, death was defined only by the cessation of heart and lung function. The Harvard criteria allowed for the recognition that a person could be dead even if machines kept their heart beating. This made organ transplantation possible and provided clarity for end-of-life decision-making. However, this definition has also been controversial. Some bioethicists have questions whether brain death truly represents the death of the person, given that the body can still be maintained with technology. Okay? And this debate until now continues. All right? Now, understanding death determination is crucial for organ donation, which has its own complex legal and ethical framework. Okay? So, organ donation. Now, let's talk about the legal and ethical aspects of organ donation. Organ donation is one of the most ethical, complex areas of end-of-life care. Let's examine the key principles. First is the dead donor rule. This is the universal ethical and legal rule that donors must be determined to be dead first before their organs are recovered or harvested. You cannot kill one person to save another. And this rule is foundational to organ transplantation ethics. There are two types of organ donation. First is the donation after brain death, or the DBD. This occurs when death is declared based on the irreversible loss of brain function. Organs are typically procured 24 to 48 hours after death is declared. In some rare cases, it can extend up to 5 days. This is the traditional form of organ donation. Another type is the donation after circulatory death. This occurs when death is declared based on the heart stopping. After life support is withdrawn, the heart stops beating. There must be 2 to 5 minutes of sustained cessation before death can be declared. Then organ recovery begins immediately. So DCD, or donation after circulatory death, has become increasingly important. In the United States, more than 7,200 DCD donors made up 43% of all deceased donors of organs. Now, what are the key ethical principles? First, the Organ Procurement Organization, or the OPO, and organ recovery team cannot participate in the decision to withdraw care. Okay? So there must be a clear separation between the decision to end life-sustaining treatment and the decision to donate organs. So the team responsible for organ procurement and organ recovery cannot participate in the decision to withdraw care. Second, the decision to withdraw care must occur. Now, the decision to withdraw care must occur okay, before any discussion about organ donation. The patient's medical team makes the decision about withdrawing care based on medical judgment and the patient's wishes. Third is the family must give consent for organ donation after death is declared. In the Philippines, organ donation requires explicit consent. Now, these principles ensure that organ donation doesn't create a conflict of interest, that we don't withdraw care to get organs, and that death is declared independently of the desire to donate. Okay, is that clear? Now that we have this foundational understanding, let's explore dignity in death and dying in more detail. Dignity is a central concept in end of life care. Okay? What does dignity mean in the nursing context? Dignity refers to respecting the inherent worth and value of each human being, regardless of their condition or stage of life. It means treating patients as persons and as cases and not as cases, no, or conditions. The nurse's role is a steward of life, not a master of death. And this is an important distinction. As stewards, no, we we preserve health whenever possible. We prevent illness, we alleviate suffering, and when curing is no longer possible, we provide assistance toward a peaceful death. Okay? And that is according to our code of ethics. No, the code of ethics for Filipino nurses states, when the foregoing are not possible, assistance towards a peaceful death shall be the nurse obligation. This means we don't give up on patients. We don't abandon them. We continue to care for them, even when we cannot cure them. We ensure their dignity is maintained. Their pain is managed. Their spiritual needs are addressed, and they can die peacefully with respect. In the Filipino context, dignity is deeply connected to family and religious beliefs. A dignified death often means being surrounded by family, having received the sacraments for Catholics, and having one's wishes respected. So that is what dignified death means, no, in our culture. Now, one of the most challenging aspects of dignity and end of life care is the question of euthanasia and prolongation of life. Let's explore euthanasia and prolongation of life. This is perhaps one of the most ethically complex topics that we will discuss. So let's break it down. Euthanasia is the direct action to end life. It comes in two forms, active and passive. Active euthanasia is also called mercy killing. That is taking a direct action to end a patient's life. And this is illegal in the Philippines and most countries. It is considered murder under the Philippine law. Now, how about passive euthanasia? This is withholding or withdrawing life-sustaining treatment. This is different from active euthanasia. In the Philippines, passive euthanasia is permissible under certain conditions, like when treatment is futile or disproportionate, when the treatment is already useless or disproportionate, and when consistent with the patient's wishes. Okay? Now, how about prolongation of life? It refers to using technology to sustain life when the body can no longer maintain it on its own. No, this includes ventilators, dialysis, artificial nutrition and hydration, and other life-sustaining treatments. Now, what is the conflict? When does caring become suffering? This is the central ethical question. On one hand, we want to preserve life because life is sacred. On the other hand, we want to prevent unnecessary suffering. Sometimes prolonging life with technology actually increases suffering without providing real benefit. And this is where the concept of futility becomes important. Treatment is futile when it offers no reasonable hope or benefit, no? Hope or benefit, or when the burden of treatment outweighs any potential benefit. Now, in the Philippines, the distinction is clear. Active euthanasia is illegal, but withholding or withdrawing futile treatment when consistent with patient wishes and ethical principles is permissible. Okay? Now, this tension leads us to consider the inviolability of human life. So let's examine this principle. The principle of the inviolability of human life is a foundational concept to nursing ethics, especially in the Catholic influenced context of the Philippines. Life is sacred from conception to natural death. That is the key principle of the inviolability of human life. Again, life is sacred from conception to natural death. Take note, conception to natural death. This means human life was inherent. Human life has inherent value that cannot be violated. It's not about the quality of life, but about the very fact of being human. So, what is the nursing implication? This creates an important balance for nurses. First, we have the obligation to protect life. This is fundamental to nursing. We do everything we can to preserve life. Second, we also have the obligation not to impose useless or extraordinary burdens on the patient. This is crucial. Not every medical intervention is required. We don't have to do everything possible if it doesn't provide benefit and only causes suffering. And this leads to the distinction between ordinary and extraordinary care. Okay, so what is the difference between ordinary and extraordinary care? Ordinary care involves providing nutrition, hydration, comfort measures, and treatment that offer a reasonable hope of benefit. And ordinary care must always be provided. Again, it includes providing nutrition, hydration, comfort measures, and treatments that offer a reasonable hope of benefit. For extraordinary care, it refers to treatments that are excessively burdensome, expensive, or offer no reasonable hope of benefit. These are morally optional. Okay? The challenge is determining what's ordinary versus extraordinary. This requires careful consideration of the patient's condition, the likely benefits as well, the burdens, and the patient's values and wishes. Now, in the Filipino context, influenced by Catholic teaching, there's a strong emphasis on preserving life. But there's also recognition that not all medical interventions are morally required. Okay? Closely related to the inviolability of life is the concept of the right to die. So let's explore the right to die. The right to die refers to a patient's autonomy to refuse treatment. This is different from euthanasia. Refusing treatment is not the same as actively ending life. Okay, again, refusing treatment is not the same as actively ending life. The patient's autonomy to refuse treatment, which is the right to die, includes the right to accept or refuse medical interventions, even if those interventions might prolong life. Now, what is the legal status in the Philippines of the right to die? Patients have the right to accept or refuse treatment. This is based on the principle of informed consent and the right to bodily integrity. However, active euthanasia remains illegal. Okay? Right? Now, there is this, I think, a case, a case in the Philippines, Cruz versus Secretary of Health in Philippine jurisprudence. This case helps establish the patients have the right to make decisions about their own medical care, including the right to refuse treatment. However, there's an important cultural shift happening in the Philippines. Traditionally, family members made medical decisions for patients. often without consulting the patient directly. And this was based on the idea that families know what's best and should protect patients from difficult truths. But there's growing recognition of patient self autonomy. The shift is from family decision making to respecting the patient's right to decide for themselves. This includes the right to know their diagnosis, even if the family wants to hide it, and the right to refuse treatment. As nurses, you play a crucial role in this transition because you're often the ones advocating for patient autonomy while also supporting the families through their difficult decisions. Okay, is that clear? Now, another critical tension critical ethical tension is between the quality of life and the sanctity of life. Let's examine this now. This tension no, is central to many end of life ethical dilemmas. So, what is first the sanctity of life? This principle again states that life is inherently valuable, regardless of condition. Life has value simply because it is human life. A person with severe disability, like advanced dementia, or a person in a persistent vegetative state, still has the same inherent worth as a healthy person. So, from this perspective, we cannot judge a life as not worth living. How about the quality of life? Quality of life refers to judgments about the value of life based on its perceived quality, no, physically, mentally, and socially. From this perspective, a life with severe suffering or minimal consciousness might be considered to have low quality and thus less value. Okay? Now, what is the ethical tension here? Who, who now defines the quality? This is the crucial question. If the patient defines quality, then respecting their assessment is an expression of autonomy. A patient might say, this quality of life is not acceptable to me. If the healthcare, on the other hand, defines quality, this can lead to paternalism, which is making decisions for patients based on the healthcare team's values. And this is problematic when patients come from different cultural, religious, or socioeconomic backgrounds. Now, in the Filipino context, this tension is complicated by Catholic teachings that emphasize the sanctity of life, no, and by family values that may prioritize preserving life at all costs. Okay. Um, one example is should a 25-year-old with severe brain injury be kept alive indefinitely if there is no hope of recovery? What if the family insists on it? What if they can pay for long-term care? These are the kind of questions that have no easy answers but require careful ethical considerations. Okay? Now, related to this tension is the distinction between withholding and withdrawing treatment. So let's explore these concepts now. Um, th- there's actually an important ethical question. Is there a moral difference between withholding treatment and withdrawing treatment? So, what is withholding and withdrawing? Withholding treatment means not starting a treatment. For example, not intubating a terminal patient who doesn't want mechanical ventilation. Withdrawing treatment, on the other hand, means stopping a treatment that has already been started. For example, removing a ventilator from a patient who has been on it for quite some time. Now, the ethical consensus is most ethicists and professional organizations agree that there is no moral distinction between the two. Both are permissible if the treatment is disproportionate or useless. Now, why is this important? Because sometimes healthcare providers and families feel more comfortable with withholding treatment than withdrawing it. But actually, ethically, they are the same. Okay? The key considerations are, is the treatment providing real benefit? Is the treatment proportionate to the expected benefit? Is it consistent with the patient's values and wishes? If the answer is no, then both withholding and withdrawing are ethically permissible. Now, in practice, this means that if a treatment is futile or useless, you don't have to start it. And if a treatment that was started becomes useless, you can stop it. The moral burden is the same, no, in both cases. However, of course, psychologically and emotionally, people find it harder to withdraw treatment. There's a feeling that once we start, we cannot stop. But this is actually not ethically correct. We must be willing to reevaluate and, if appropriate, withdraw treatments that are no longer beneficial. Okay? Now, when curative treatments is no longer the goal, palliative care becomes essential. So let's explore palliative care and hospice care. Uh, Palliative care and hospice care are specialized forms of end-of-life care. Let's understand what they are and how they differ. The goal, of course, is to relieve patients of suffering, no, not cure. This is the fundamental shift, no, from curative to palliative. And we're no longer trying to fix the underlying disease. We're trying to manage symptoms and improve quality of life. The focus is pain management and symptom control. This includes aggressive pain management, control of nausea, dyspnea, anxiety, and other symptoms. The goal is to make the patient as comfortable as possible. For palliative care, it can be provided at any stage of serious illness alongside curative treatment. Palliative care is not just for the dying, it is also for anyone with a serious illness. While hospice care typically is for patients with a prognosis of 6 months or less, if the disease follows its normal course. The focus is entirely on comfort, not cure. Now, the principle of double effect is a crucial ethical principle, no, in palliative care. It states that an action with both good and bad effects can be morally permissible. And there are four conditions, as we have discussed in the previous discussion, no, in the previous module. So just to review again, the four conditions are: the action itself must be good or neutral. The good effect is intended, not the bad effect. The good effect is not achieved through the bad effect. And that lastly is the good effect outweighs the bad effect. Now, in practice, this means we can administer morphine to relieve pain, even if it may inadvertently hasten death. The intent is pain relief, not death. The hastening of death is a foreseen but unintended side effect. In the Philippines, as we noted, only 10% of hospitals have palliative care units. This is a significant gap. As nurses, you may need to provide palliative care even in settings without formal palliative care programs. Okay? So to provide palliative care effectively, we need informed consent. So let's review again the informed consent. No? But of course, I will not anymore discuss this because it has been discussed previously, no, in the previous module. Okay? Sometimes patients lose capacity and cannot make decisions. And that's where advanced directives become important. So let's explore advanced directives. Advanced directives allow people to plan for their future, no? For their future healthcare, particularly in case they become unable to make decisions. And there are two types, no, of advanced directives. First is the living will. It is a written document that specifies a person's medical treatment preferences. Okay? If they become seriously or terminally ill and cannot communicate. So this will details, no, their preferences on their medical treatment. It might specify which treatments they want or don't want. For example, no mechanical ventilation, no CPR, no artificial nutrition and hydration. Okay? Now, the next type is the durable power of attorney for healthcare. This designates a surrogate decision maker, someone the person trusts not to make medical decisions for them if they become unable to decide for themselves. Now, this person should know the person's values and wishes and should be willing to advocate for them. So I think I have also mentioned this already in the previous module. Now, in the Philippines, advance directives are not yet widely legislated as a standard practice no, in all Philippine hospitals. However, the ethical duty to respect a patient's prior wishes stands, regardless of legal requirements. Advance directives can take many forms. It can be in a formal legal document, or it can be a simple written statement. It can also be a verbal expression to family members, or something that had been discussed by the patient with healthcare providers. The key for advance directives is clarity and specificity. The document should clearly express the person's wishes about specific treatments and situations. Okay? Now, that we have covered the foundational concepts, let's uh, okay, let's discuss the nursing roles and responsibilities for end of life care. No, first, you know very well that nurses play multiple crucial roles. No, and it's also the same in end of life care. First is being an advocate, speaking for the patient's wishes and rights. This means ensuring no, that the patient's voice is heard, even when the patients cannot speak for themselves. It might mean advocating for pain management or respecting a do not resuscitate order or ensuring the patient's cultural and religious practices are honored. Like, for example, for Catholics, they might request uh, for anointing of the sick, no, for the last sacraments to be given to them. So we can facilitate that, and we need to ensure that they receive that as the patient's advocate, okay, because they are Catholics. Next is for playing the role as an educator, informing families about prognosis and realities of care. Families often don't understand what's happening, what to expect, or what their options are. Nurses provide crucial education and information to help families make informed decisions. Next is the caregiver role, providing comfort, hygiene, and pain relief. This is the hands-on care that nurses provide, like managing pain, keeping patients comfortable, providing personal care, and ensuring dignity is maintained in every interaction. Then the next one is the counselor role, supporting emotional and spiritual distress. End of life care is emotionally difficult both for patients and families. No, nurses provide emotional support, listen to their concerns, and connect patients and families no, with spiritual resources if they desire. Each of these roles requires different skills but are all essential, and they often overlap. You might be providing comfort while also educating family or advocating while also providing emotional support. In the Filipino context, the counselor role is especially important given the strong religious and spiritual dimensions of death. Many patients and families find comfort no, in prayer, sacraments, and spiritual conversations, and nurses should be prepared not to support these needs. Okay? Now, fulfilling these roles requires a systematic approach no, to ethical decision making. So again, we review no, these steps, but I will not anymore discuss them since we have discussed this in the previous module. Now, let's take a look at this ethics committee simulation. Actually, I need all group one, no, to present this ethics committee simulation. You can write a script about this scenario, demonstrate how this situation is going to play out. No, you can utilize online tools to help you write the script. What's important here is the dialogue, the conversation that takes place in an ethics committee simulation that focuses on this scenario. So the scenario is a 70-year-old man is comatose. The wife said, "Please, doctor, do everything." While the children says, "Please let him go. He is suffering." Okay? So yon. So let's hear from the group one, no, in an assigned or appointed schedule, no, to role play this ethics committee simulation of this scenario. Right? Now, for you to better understand how to apply ethical principles and concepts of healthcare ethics on cases for death and dying, let's have this first case scenario, the morphine dose. No, this is the case of Mr. A. Mr. A is in terminal pain from advanced cancer. Increasing the morphine dose is necessary to relieve his agony, but it will likely depress his respiration and hasten his death. The ethical conflict is this is actually a classic tension between beneficence, which is the duty to do good and relieve suffering, and non-maleficence, which is the duty to do no harm. Relieving pain is good, but potentially hastening death seems harmful. So, what is the proposed decision? It is to administer morphine. The justification is that this is an application of the principle of double effect. The intent is pain relief, not death. The hastening of death is foreseen, but it is not the intention. No, it is not the intended consequence because the intention is to relieve pain. Okay? Now, for the to analyze, no, if this decision or action is morally correct, let's take a look at the action or the object itself, which is pain relief by administering morphine, which is good because pain relief is a good action. For the intention to alleviate pain, that is also a good intention. The intention is not to cause death. The intention is to alleviate pain. For the circumstances, there is proportionate reason that exists. The patient is in severe pain that cannot be relieved by other means. No, as long as there is a doctor's order, no, of the morphine and its appropriate dose, then it and with the patient's consent, then it can be administered. So that is a favorable or reasonable circumstances. Then how about the outcome? Pain is relieved, so that is a good outcome. Although death is foreseen, but it is not intended. It might be a side effect because morphine, of course, can depress no respiratory function. Now, this scenario illustrates that sometimes the good actions can have unintended bad consequences, but the action can still be morally permissible if the intention is good and there is a proportionate reason. Okay? Now let's have another case, the DNR order or the do not resuscitate order. Mrs. B is an 80 years old 80-year-old has terminal cancer with a valid DNR order. Valid meaning she signed it when she was still well. No, so there is a do not resuscitate order. She goes into cardiac arrest. Now, a new nurse rushes to start CPR saying, "I want to save a life." Okay? Now, the ethical conflict is that this is a tension between the nurse's conscience or values, which is the desire to save life, and the patient's autonomy, the right to refuse treatment. The the right to refuse treatment was already laid out in the do not resuscitate order. No, it was signed by the patient previously. But the nurse believed saving life is always good. On the other hand, the patient has expressly refused CPR. Okay? Kasi nga, meron siyang DNR or do not resuscitate order. Now, what is the proposed decision? It is to respect the do not resuscitate order. Do not initiate CPR. And the justification for this is that the is to follow the principle of autonomy. The patient, when competent, made a clear decision to refuse CPR has to be respected. No, this right to refuse treatment must be respected even if the healthcare provider disagrees with the decision. Okay. Now let's analyze that decision and if that action is morally permissible. The respecting the do not resuscitate order is good because it respects the patient's rights and autonomy. For the intention to honor the DNR is the intention is to comply with the patient's expressed wishes, which is actually a good intention also. For the circumstances, there is a valid legal and medical order existing, the do not resuscitate order. For the outcome, death occurs naturally without the trauma of the unsuccessful CPR. Now, this scenario highlights the importance of respecting the patient's autonomy, even when it conflicts with our personal desire to save life. It also emphasizes the need for all healthcare providers to be aware and respect advance directives and do not resuscitate orders. Now, our third scenario involves the difficult question of futile treatment and family hope. The futile ventilator or the useless ventilator. This is the case of a young man who is brain dead following an accident. The ventilator is keeping his heart beating. The family refuses to disconnect him, believing a miracle will happen. The doctor wants to withdraw support as the patient is already legally dead, following the legal definition of death. Now, what is the ethical conflict? This is a tension between the sanctity of life, the family's view that life must be preserved at all costs, and medical futility, the team's view that continued treatment offers no benefit. The family holds on to hope. The medical team sees the reality. Now, what is the proposed decision? To continue the communication with the family and to continue ethics consultation with the family. And eventually, once the family agrees, withdrawal of mechanical support can be done as it only prolongs the dying process and offers no real benefit. So what is the justification for this decision? It is following the principle of non-maleficence. Providing futile treatment is also harmful. Psychologically to the family, it is harmful. Financially to the healthcare system also, because many needs ventilators. Many patients needs ventilator. So yun. And also, it actually offers no benefit to the patient who is already legally dead. Now, continuing the ventilator doesn't restore life. It only delays the inevitable. Okay? Now, let's analyze if this decision or action is morally permissible. First, for the act or the object, it is to withdraw the ventilator. It is good because ceasing useless treatment that offers no benefit is good. For the intention, which is allowing natural death to occur rather than artificially prolonging the dying process, that is also a good intention, allowing natural death. For the circumstances, brain death is irreversible and meets the legal definition of death. For the outcome, the family can achieve closure No, the possibility of organ donation can also be explored. Now, this scenario is particularly difficult because it involves a young person, making the family's hope for a miracle understandable. However, brain death is a legal and medical reality that must be acknowledged. Continued communication with the family, compassion, and time for the family to grieve and accept the reality are all essential. And our role as nurses is important, no, in this part. Okay. One. Now, so what are our key takeaways, no, in this module on compassionate closure? Okay, that end of life care, no, is about the quality of the remaining life, not just about the length. It's about living as fully as possible until death, not just about dying. Second, ethical decisions require balancing multiple principles: autonomy, beneficence, non maleficence, and justice. No single principle always dominates. We must weigh them carefully in each situation. Third, moral evaluation involves looking at four elements. No, the act, the intention, the circumstances, and the outcome. Okay, and this framework helps us analyze, no, the situation or the action. No, it helps us think through complex ethical dilemmas, so we can develop our ethical decision making skills. And then fourth is communication. Communication with families, no, is a core nursing skill in end of life care. This includes providing information, listening to concerns, navigating cultural differences, and supporting families through difficult decisions. Okay? Compassionate closure is the ultimate privilege of nursing. We stand, no, in the gap between fear and peace. Okay? Between suffering and comfort. And this is actually a sacred work that requires knowledge, skill, compassion, and ethical integrity. Okay? So I think that would be all now for our discussion on compassionate closure or end of life ethics and end of life care. Okay? Thank you everyone again for listening.